So yeah, I'm Catherine Chaplin, or Cat, and as Gail said, I'm a senior scientist at AWTTC, although originally I was a medical writer, so one of my main roles was doing the literature searches and then writing the first draft of the evidence status reports, or ESRs. So today I'm going to talk about the process we go through when completing the clinical effectiveness section of the ESR. So when we're doing a One Wales Medicines assessment, our main aim, so we're trying to make sure that the medicine is safe. We're trying to see if there's any scientific justification for why that medicine may be effective in a particular patient group. But overall, our main aim is to make recommendations that are based on the best evidence available. So how do we go about finding that evidence? And then once we found it, how do we appraise that evidence? So I'm going to give a very brief overview of doing the literature searches, how we search for the evidence, and go through what's called a PICO table, and then discuss evidence hierarchy and the sifting process. And then the most of the presentation is going to look at how we appraise that evidence, so its interpretation, analysis, and its applications and implications in a wider population. Right, so the PICO table. This is written before doing the search, and it stands for participants, interventions, comparators, and outcomes. And the below is an example of one we did recently for that azacitidine assessment. So what we'll go through is clearly define the population of interest for the indication that we're considering. We want to be very specific in terms of the intervention as well, so dosing schedules. We'll identify what our main comparator is, and this may come from literature, it may come from clinicians, it may come from the requests we've received. And then finally, we'll want to outline what we think some key outcomes are for this population. Generally, this will be used to specify the search terms that we would put in when doing the searches. However, for a One Wales Medicines assessment, given that most of these are off-label use of existing medicines, we do generally try and keep our search terms quite broad. So we'll generally only include, say, the medicine name, so the generic name, the trade name, and the condition that we're interested in, to make sure we try and get all of the available evidence. So where do we search? So the first place we'll go to is all the major databases, and we're looking for any published papers, conference proceedings, or reviews that may have been done already. Then we'll also expand it and look at other sources, so equally important. So trial registries is another one. We'll want to look at, are there any ongoing trials at the moment using this medicine in this population, or have there any that are being completed? And if so, we can then go and specifically look to see whether any results or preliminary results from these trials have been published anywhere, even if it's just a conference abstract. We'll look at other national bodies, organisations and groups to see if they've published guidelines or if they've got anything that may be useful for us. And finally, we'll also contact the industry. So when a submission is made, we will contact the marketing authorisation holder to ask if there's any relevant information that we should be aware of and needs to be considered. So once we've done the literature review, we can have anything from a handful of studies to hundreds of studies to sift through. The evidence can be from a range of different study types, and these are summarised in this pyramid. So at the bottom of the pyramid, we've got the very initial animal and lab studies, which aren't going to be relevant to us when we're doing a One Wales assessment. On the next step up, we've got the descriptive case studies or expert opinion pieces, editorials, and these normally just refer to one patient or one clinician's experience of a handful of patients. We then move into sort of primary studies. So these are case control studies, case and cohort studies. These can either be retrospective, so the investigators have gone back and looked through their records and found patients that have had exposure or have had the disease, and then they'll look at what happened to them. Or they can be prospective, so they'll identify the two groups of interest, and then we'll follow them forwards to see what ends up happening to them. So an example of this might be a single arm phase 2 study. And then finally, at the top of the primary studies, there are randomized controlled trials. The very top of the pyramid relates to what's called secondary evidence. So these are when more than one primary study is included. So examples of this are systematic reviews, meta-analyses, or clinical practice guidelines. For a One Wales medicine assessment, generally we will only get primary studies, and these can be both randomised and more often than not non-randomised studies. Occasionally we might find some real-world data or registry data. However, generally speaking, this is difficult to come across and difficult to find unless it has been published or presented at a conference. So the type of data that we found and included will determine how we think about it and what considerations we make when deciding whether to include it or not. And I'm going to go through all of these now. But other considerations we'll make when we're sifting through the evidence to decide whether to include it or not might be the language that was actually used to write the original paper, where the study was conducted and how generalisable it is to Wales, the number of patients that were included in the study, and what the publication type was. So if it's a conference abstract where we've got a very limited amount of data that's presented there, if it's a full paper, and where it's been published, so has it been peer reviewed. The amount and level of evidence that we'll identify will vary significantly across One Wales Medicine's assessments. Okay, so as I say, the remainder of the talk, I'm going to focus on this critical appraisal of results. There are some formal tools out there that can be used, and I will talk about these later on. But when we're doing a One Wales Medicine assessment, we're doing it on a much more internal level. So we don't have a strict checklist that we follow. These are just things that we'll have in our minds when we're going through the studies, and that will help us identify any areas of concern or flag anything that we might like to check with clinicians or senior members of staff before proceeding. The appraisal is split into different sections, which are listed here. So population, for this we're specifically looking at selection bias, and I'm going to talk through each of these in turn in a bit more detail. When we look at the intervention, we're looking for concerns with performance bias. Outcomes, it'll be measurement bias. Analysis, we're looking for reporting bias. And then we'll look at interpretation and publication bias. So broadly speaking, we're looking at how the patients were selected. Were there any systematic differences in how the treatment was provided to the patients? What outcome measures were used, and were they the same across all the groups? Is missing data accounted for, or was it controlled for? Which results were reported and which weren't? And highlighting that it's only based on results that have been published. Regardless of the study design, all studies should start with a clearly defined and focused question. So I've created a table like this for each of these sections. The table split into two columns. So on the left-hand side, you'll see this relates to randomised controlled trials, or RCTs. And on the right-hand side, it relates to non-randomised studies of interventions, or NRSIs. And so I'm not going to go through all of these in detail, but these are the questions that I've taken from numerous tools that are used to formally assess risk of bias in studies. Basically, for RCTs, what we're looking at is, were patients randomly assigned, and could investigators work out which group a patient would fall in before deciding whether to include them in the trial or not? So things like if it's done based on year of birth or clinic date or the last digit of an NHS number. Commonly, we'll compare baseline characteristics at the start of the study to see if there's any differences between groups, as this is one way of flagging any potential selection bias. Finally, we'll also check whether blinding was possible, and if so, was it done? For NRSIs, we want to see, were patients recruited in an acceptable way? Was everyone included who should have been? And again, looking at baseline characteristics may offer some reassurance or raise some concerns about this. The aim of all of this is to assess selection bias. So were the patients selected or not selected to be included in the study or in a particular arm of the study? And if so, that would be a cause for concern. For the interventions, the considerations are actually quite similar for randomised and non-randomised studies. We want to make sure that interventions and methods are clearly defined. So based on the information provided, would we be able to replicate the study? And can we replicate what the intervention was and compare it to the intervention we're interested in? We want to check that aside from the medication or the intervention of interest, were there any differences between the two groups for the remainder of the care that was provided? So was there any unbalanced provision of additional interventions or co-interventions? Or are there any differences in these co-interventions between the groups? The length of follow-up should also be the same for each of the groups. We'll also check for any other protocol deviations. So it might be that control group is contaminated and some receive the exposure or the medication of interest. There might have been inadequate blinding of care providers and or patients. So what we're assessing here is performance bias. So we're looking at, aside from the intervention of interest, were there any differences in the treatment between the groups which could account for the outcomes? So blinding is an important tool here, as that may reduce the risk that knowledge of whether someone received the intervention or not can affect the outcome. So for outcomes, we want to know exactly what the outcomes of interest were and that they're clearly defined. We need to know how they're measured. Were these standardised measures? Were they subjective or objective? Who were they completed by? Was it patients, carers or clinicians? We want to look at the timing of them. Were they done at all time points or just some time points? And was this the same for all of the groups? And what we're looking to do is assess measurement bias or information bias. So we're assuring that the outcomes weren't measured or calculated differently for the different groups, because that may lead to one group appearing to have performed better than another. We might look at what measure they've chosen. So if there's a standardised measure available, but they've chosen a different one, why might that be? But measurement bias can also be an issue for anything else that's measured in a study, so confounding variables, but also for allocating patients, for example, in retrospective cohort study, and determining whether a patient has or has not been exposed to a particular interventional medicine. Blinding, again, of outcome assessors may reduce the risk of outcome bias. And these are especially important for subjective outcome measures, so things like pain. If the outcome assessor knows whether the patient has received the medication or not, that may influence the way they record or score their pain. Right, so I'm going to move on to the statistical and analysis section yet. But first of all, we thought we might just put up some jargon buster. I just want to highlight, you don't need to understand or need to know what all of these are for the sake of this talk. I'm just giving a very broad overview here. But these are terms that I think come up quite frequently, and they can sometimes be misunderstood or confused. We will be providing a list of useful websites and resources at the end of this talk, and that will be made available to you. And also it might be worth highlighting again here that if there's anything in any of the talks today that you'd like more information about or us to cover in more depth in future, then please let us know. So in terms of the ones on here, first one is absolute risk reduction. So this is the difference in rates between the experimental and control participants in a trial, and it's calculated as the difference between the experimental event rate and the control event rate. So if we had 10 patients out of 100 in the experimental arm who experienced an adverse event, so 10%, and we had 40 patients out of 100 in the placebo arm who experienced the event, so 40%, then the absolute risk reduction is just the 40 minus the 10, so it's 30%. A risk ratio allows a specific number to be given to how much more risk an individual in one category bears compared to an individual in another category. These are generally quite easy to understand. and they have the assumption of causal direction, which means you can show whether an intervention or the medicine has had an effect on the outcome. So if we looked at the previous example I gave, where our experimental rate was 10% and the placebo rate was 40%, then to calculate the risk ratio, we do 10% divided by 40%, which would be 25%. An odds ratio looks to measure a treatment's clinical effectiveness, and this is looking at an association. You can't make causality assumptions for an odds ratio. And this looks at the number of events of interest. Instead of in relation to all events, it just looks at the number of events of interest in relation to the number of events not of interest. So an odds ratio provides a measure of the strength of the association between two variables on a scale, and 1 means there's no association. Above 1 shows a positive association, and a value below 1 shows a negative association. So in my previous example, in this case, the experimental rate isn't 10%, the 10 divided by 100. It would be the 10 divided by the 90. So the number of patients who had an adverse event divided by the number of patients who didn't. And so the control rate would be 40 divided by 60. And this gives us an odds ratio of 0.167. Whereas the risk ratios and odds ratios are static and they just summarise an overall study, hazard ratios can look at the rates of change over time. So a hazard ratio of 1 indicates that the likelihood of the event was equally likely at any given time. An HR not equal to 1 indicates that the events are not occurring at an equal rate, and so the risk of an individual in one group is different than the risk of an individual at another group at any given time point. So they're the key sort of stats things that may come up. Other considerations or other useful terms when going through this are confounding factors. So these are other things which may account for any relationships identified between the intervention and the outcome. Confidence intervals. So this shows the amount of variation of a result, and it's also how representative the study sample is of the wider population. P-values show whether statistical tests are significant or not, and power calculations are used to work out how many patients a trial needs to recruit in order for it to be able to find meaningful results. Okay, so moving on to analysis. This is the largest section and it has the greatest number of queries associated with it. I've included many of the tool questions on here, but the key questions that we'll be thinking about when looking at RCTs were the number of patients completing the trial similar in each arm, or was there a high level of attrition in one arm? And that may raise questions re acceptability of certain arms. Is missing outcome data reported, and is it controlled for in the analysis? Did the analysis include all the patients that were randomised to each group? So this is called an intention to treat analysis. Or did they only include those who followed the protocol? Were the correct tests done, and were the right statistics reported? For non-randomised studies, we're looking at consideration of potential confounding effects, and that's particularly important for non-randomised studies. In addition, we'll look at whether follow-up was sufficiently long enough in order for both positive and negative effects to be revealed. Were appropriate tests done and the right statistics reported? This is also used, so this is used to assess what's called reporting bias, and the key point is to check whether all the outcomes are reported at all the time points or only selected results reported, and why might that be? Also, within the published study, we know that statistically significant results are more likely to be reported than non-statistically significant results. And this within study bias may also be one of the most substantial biases affecting results from individual studies. So we will, generally go back and look at the methods section, look at all the outcomes they said they were going to collect, and check whether all of these are reported in the results or not. So interpretation. So are there any systematic differences between the reported and the unreported findings? So are there differential reportings of outcomes or harms compared to benefits? Is there differential reporting of results between the groups? What was the size of the effects? And could these results be due to something other than the intervention of interest? So as I say, there are some tools available that assist with assessing all of these domains that I've discussed. So for RCTs, there's the Risk of Bias 2 tool, and for non-randomised studies of interventions, the Robbins tool. There's also the Gradings of Recommendations, Assessment, Development and Evaluations, or the GRADE tool. So up until this point, I've covered things that we think about when we're identifying and summarising clinical effectiveness data. So once we've sifted through our results, these are all the things that we're sort of mentally going through and deciding on how robust and how good the clinical evidence is that has been presented. And these may raise things that we'll include in the issues part of the ESR. I'm going to move on to next is things to think about once you've received these ESRs or once they're sent to the OWMAG meetings. So again, this is not a comprehensive checklist of questions that need answering. It's just a useful guide that you might like to look at or help you think critically when you're reading the ESRs. So when looking at the results of any study, what we want to ask is how generalisable are the findings to a wider population? And this is especially important for One Wales Medicine's assessment, where we can be looking at a very specific patient group or indication, which is likely to be different to those previously studied. When considering the results, we want to apply it to our population. So this could be at an all Wales level, or in some cases, it might even be appropriate to do it at a health board level. And here are some of the key questions you might like to ask yourself. So was the evidence presented include similar patients? Would any differences alter the outcomes reported? Are the outcomes reported important and clinically relevant? Are there outcomes missing? Is it possible to quantify local benefits and harms? And were there any limitations with the evidence that would affect the decision about whether we should implement this intervention or not? So in terms of implications, what we want to know is, would we expect this new intervention to provide greater value than any of the existing interventions? And what do we mean by value? So value is realised when an intervention achieves the best possible healthcare outcomes for our population with the resources we have. Therefore, careful consideration needs to be given to resource and infrastructure costs in addition to the medication costs. And so things might be time, money, training, setup costs, clinic costs, all these kinds of things. We also need to consider whether it might be possible to disinvest resources from one or more of the existing interventions in order to help fund the new one. Implications, so specifically for the non-randomised studies, what's going to count as sufficient evidence to support the implementation of a new intervention? So a single observational study on its own is rarely going to provide sufficient evidence to recommend changes to clinical practice. However, for certain questions, observational studies may provide the only evidence. So what are we going to consider, is good enough then for inclusion? So recommendations from observational studies are always stronger when they're supported by other evidence. So this may be ideally other types of evidence, so some more robust data, or it might be replication of the evidence across other studies and settings. Okay, so I've mainly focused on primary studies, so single studies, as that's what the bulk of the evidence we find is. However, just a quick word about secondary studies and reviews. So generally there are three types of reviews. There's a systematic review, a meta-analysis, and a network meta-analysis. As the name suggests, systematic reviews are when a systematic search has been done of all available literature. They have to have a very clear question and a very clearly defined PICO table, and this will be used to determine search terms and used for the sifting of the results. The review will only provide an overview of the key study characteristics, the baseline patient characteristics, and will summarise the key results from each of the studies identified. A meta-analysis is when the data or results from multiple studies are combined into a larger analysis. They will usually show the individual results plus an overall result, And again, they'll only report an overview of the included studies. Meta-analysis can only include what are called direct comparisons. So the studies need to have compared, say, the medicine versus the placebo, or the new medicine versus the existing medicine, whatever the interest is of that review. However, sometimes there is no direct evidence available, and in this case, it's sometimes possible to calculate indirect effects. So in the diagram below, there's a study we found that compares the new medicine with placebo, and we found a study that compares the existing medicine against placebo. And the results from these two studies can be used to calculate or estimate the effect between the new medicine and the existing medicine. And this is an indirect comparison. So a network meta-analysis will combine the results of multiple studies into a large analysis, but it will include both direct and indirect comparisons. So it can be good to find secondary reviews where people have already looked at these things for us. However, it's worth bearing in mind that papers may have been excluded from a review, studies may have been excluded, which are actually relevant for us. Although, like Cochrane reviews will provide a table showing all the studies not included, many published systematic reviews won't. Therefore, it's still important for us to do a thorough literature search ourselves. Even if the study is included in the review, it's still important that we go back to the original paper in order to fully appraise the study for our assessment needs and to get more detail. The results of the reviews are only as good as the data put into them. So evidence from a review of many poorly conducted studies may be less valuable than a single robust randomised control trial, for example. Even if multiple studies have been done, it isn't always possible and it isn't always correct to put them into a combined analysis. So again, are the populations of the studies similar enough? Were they all done within the defined population? Were the interventions similar enough and the comparators? And were the same outcomes used? Were they measured at the same time points using the same measure? So this brings me nicely back to the importance of our PICO table. It all comes down to population, intervention, comparators, and outcomes. So I've just got one final slide with regard to the One Wales Medicines Review assessments. So a lot of this has been covered, but we will search to see if any new evidence has become available since the previous review or the original assessment. We look at the quality of the new evidence. Is this the same? Is it better or lower than the evidence included previously? Does the new evidence add anything new? And overall, does this new evidence support or question our existing recommendation? As I mentioned at the start of the talk, it can be hard for us to find real-world data for these assessments. And although these types of studies aren't ideal for the licensing process, they can provide very useful information about application in practice. And this is why the patient outcome data we request from clinicians is such an important part of our review process. I hope this talk has given you some background as to how we critically appraise the studies we include in the clinical effectiveness section, and has maybe provided you with some inspiration to change the way you look at our ESRs. As I say, we have put together some useful resources for you, and these will be circulated to you. Thank you.